Hey everyone, welcome to the Mental Playbook with Christine Dalgity. We're here to chat about all things mental health, share some awesome stories, educate, and advocate to break stigmas and gain power through knowledge for all ages and walks of life, and give you the tools you need to boost your mental game. So grab a coffee, get comfy, tune in, get inspired, and let's dive into some fascinating conversations. Remember, your mind is super powerful, and with the right tools and knowledge, you can master your mental playbook. And while you're doing that, take care of you. Hey everyone, welcome back to the Mental Playbook with Christine Dalgity. Today's episode is a little bit different. We're doing it via video because one of my psychotherapists, Mandy, is an online therapist and she lives a little ways from us. So thanks for joining me, Mandy. And today we're going, talked right over you. Today, just a little bit about Mandy. So Mandy was a student at our practice and she did so well that I hired her, and she was moving a couple hours away. So we decided that she would be a great fit for an online therapist with us. But Mandy also has another job where she, I believe, works in office. Yep. So I want to talk a little bit about the differences between online and in office as well, and just all the transitions and everything. So Mandy is a registered psychotherapist qualifying. So in Ontario, you need to have 100 hours of supervision before you can take the qualifying away and become a full registered psychotherapist. And then you need 160 hours of supervision to be a full practice where you can be a clinical supervisor too. And it might not seem like a lot of hours, but 160 hours of supervision is a lot of hours and can take a few years to do, which is why they do that, right? Because you need to get the experience. So welcome, Mandy.
Thank you.
Just to start off, I wanted to start with your transition. So if you want to talk a little bit about first being a student, and I know, unfortunately, your experience was a little bit different too, because the psychotherapist in the office that would be there for you, because we had a satellite office, went on mat leave, and then we were trying to help you, and you were kind of on your own. So a different experience, but you adapted so well to it. So do you want to just talk a little bit? There could be some people out there wanting to know, is this something they want to go into? Talk a little bit about your experience as a student?
Yeah. So looking back now that I'm kind of removed from the student space, it's kind of definitely a relief. I remember being very stressed out with kind of figuring out how to do school and work and placement and all of these kind of different components combined. But now that I am a little bit removed, it was a really great experience. In the moment you are stressed out and you're trying to make it all work and figure out scheduling and kind of all of these different moving parts. But looking back, I really do have fond memories of doing my placement, of working with you, of kind of figuring out all the different, I think because my experience was so different, it kind of opened my eyes to what maybe potentially owning a practice of my own might look like, where you are kind of figuring out office spaces and what works and what doesn't. I got kind of a lot of different opportunities to see different spaces, like the satellite office, and then moving into the other office, kind of what that transition looks like. It was, I don't know, it was just kind of a really great opportunity and lots of different experiences that I don't think I would have gotten otherwise if it was just the typical kind of placement experience, I guess.
Yeah, and I remember too, you had to go into school to see some kids in a school. And, I talk sometimes on the podcast about how when I get a student, I ask you what you prefer. And they all laugh. They all laugh because they tell me what they prefer. You tell me what you prefer. And then I say, okay, do you prefer adults? You're going to see kids. It's not to be, an ass or anything. It's because being a student, in my mind, mentoring students, I'm going to put you through things that may come up in a practice, but also if your comfort zone is adults, you need to go outside your comfort zone, because if you do go into private practice or, whatever it may be, you may want to see kids or whatever. And often, and I think it was with you too. I mean, I think you still prefer adults, but
Mm-hmm.
I remember with most of my students, I didn't think I want to work with
Mm-hmm.
adults, or I don't think I want to work with kids, but
Yeah.
I kind of like it, right?
Yeah.
And yeah, you went into schools. We had an
Mm-hmm.
office at a church.
Mm-hmm.
We had our main office. You were online. You were like
Doing
very
it all.
flexible. Yes, you did.
Yeah.
So what do you think is like the biggest shock you had, or if you had one, transitioning from student to like practitioner? Was there anything that
Um,
was like, whoa?
that's a good question. Um, there's a lot of different experiences that maybe I was not expecting. I think after maybe the placement to fully registered practitioner is maybe like the imposter syndrome I thought maybe would be a lot less. Like I think I had it and I'm still kind of working through that is like the idea like I think I had it in my head that after school, after your placement, that like that confidence level would increase, or you'd be like, all right, I got it, I'm done school, like now I'm ready to like fully practice and
Yeah,
be on not on my own, but there's kind of that title change that I think maybe I
for
thought would
sure.
be different. So imposter syndrome is definitely still something that comes up. And as I'm gaining confidence in many different areas, it is kind of, I think, probably a lifelong journey in different populations that you work with, in different situations or different clinics, different things that kind of happen. I don't know that that really does change all that much. I think you do gain confidence, but
Yeah,
I think
yeah,
that's the biggest one, maybe, is that I would
for
feel
sure.
100 times more confident, or that imposter syndrome would be not there.
Yeah, and I think that the imposter syndrome goes away more, but I mean, you're what, a year and a half
Mm-hmm.
into, after school, and um, I've been doing this for 30 years and 31 years now, and I
Mm-hmm.
still get sometimes, a client will come in that I'm kind of like, because I
Mm-hmm.
know it's something really complex
Yeah.
and, or trauma specialist, right? So
Yeah.
some of the traumas, I'm like, okay, I need to make sure I say this and this. And sometimes afterwards, I'm like, did I do everything I was supposed to? Did
Yeah.
I? And that's after 31 years of it. So I think that you absolutely every year you get more confidence.
Mm-hmm.
There's, things that I would say now to a client to, like, we say, like, call them out.
Yeah.
We're not like calling them out, but like, on
Yeah.
one hand you say this, but on the other hand you're doing this, like that, cognitive dissonance and stuff. So that I would do, where some of like you guys are like, whoa, I can't do that yet. You
Yeah.
do that very well though. I remember watching your videos when you were a student and you did that very well. And I told your prof that, yeah, you were
Oh.
like, I was like, whoa, dang,
Fake it till
right?
you
Like
make it, I guess.
she's only been into this for like a few months, and you did it so well. And the client
Yeah.
was like, yeah, that's right. You know,
Mm-hmm.
yeah, that's why you got a job with us. Uh, well, one of the reasons. But yeah, that will improve.
Mm-hmm.
It'll never go away though. I'm just going to tell
Yeah.
you that,
Yeah.
because we're responsible for someone's mental health,
Yeah.
and at times for life and death, right? And
Mm-hmm.
so that confidence, I think that you gain the confidence, but you still get that like, I hope I
Yeah.
did the right thing. I hope, and we have to go with our instinct and our
Mm-hmm.
training and our knowledge. So,
Mm-hmm.
because the minute they walk out those doors,
Out of our hands.
we can't control it,
Mm-hmm.
right?
Yeah.
So,
I think that is kind of too, like, as this journey kind of progresses with that I don't know, that gut feeling of like, did I do everything that I can? I'm learning that even just like being in the room is just as impactful as doing or saying the right thing. I think, like, again, that difference from student life or versus now, where you did want to say the right thing, and there was kind of this idealized version of like, okay, what is, as you're learning skills, like what is the right skill to use here, what's the right thing to say. And as I'm now a year and a half into um,
yeah,
being a practitioner, it's, there is no right thing to say, and even if you were to say the right thing, it's what, how the client interprets it. that I think is kind of something that I keep in the back of my head as I feel that kind of gut feeling is just like, okay, me being here is the intervention in of itself, which is hard to sit with. There's kind of those
100%.
pieces.
Yeah.
Yeah.
Yeah. Yeah. Sometimes they just need someone to validate and not judge them. And that is saving them. Right. So yeah, absolutely. We can't fix everything. And I know that sometimes clients come in and they're like, okay, what are you going to do to fix me? And I'm like, I'm not going to fix you.
Yeah.
I'm not going to fix you. I'm going to help you figure some stuff out. Right. So was there any time in your training that was kind of like a, this is exactly what I want to do. Like this, I want this to be my niche kind of thing. Was there any moment or anything that was like, or are you still trying to figure that out? Which is totally okay after a year and a half of doing it, right?
I think like I've learned a lot about kind of maybe where I want to be or maybe where like working with kids. I do find that challenging in a good way. There's kind of a lot of different skills that come out with working with youth and kids and even in teens, right? It's kind of a lot of different, you kind of have to approach it in a different way, which is challenging and interesting and kind of gets those creative juices flowing. But I think my comfort level is adults, and I'm kind of learning like anxiety might be a little bit my niche. I've always had a passion for working with addiction, so that's kind of another part that I really do enjoy working in, and I'm hoping to do EMDR training eventually. Trauma has kind of piqued my interest, just as working with addictions and like clients in general. I like 9 times out of 10 people will disclose a trauma that they've gone through that is not necessarily what they've come in for in the first place. So I think like getting to that root is really interesting for me. And I think kind of going that way might be like all throughout, like throughout placement and also like in the year and a half that I've been outside of school. Those are kind of maybe the main things that I've gravitated towards.
Yeah. I think every one of my therapists now have told me that they want to do EMDR training. And I'm like, we can't all be trauma specialists. Yeah, I mean, it's a fascinating training. And you really hit the nail on the head there when you said, a lot of times people come in with anxiety, but it's trauma rooted, right?
Yeah.
And we have little forms that we have clients fill out so that we can kind of fit with the right therapist. And we've just started it not that long ago because of the different niches that we have, and we want to make sure that we fit it, right? And it's hard because they like on the thing, it's like, oh, anxiety, depression, or relationship issues. And then as we get going in it, it's trauma. It's trauma is, that touchstone event in their life was a traumatic event and that created these, or some of the stuff that happens before the age of 8 that I've talked about before, right? That the messages and it's created it. And so, which is why you probably got an email from me. Well, you didn't probably, you did.
I did.
You probably got an email from me. I sent it, but you got an email from me that I created a little thing for trauma and suicidal ideation.
Yeah.
For all of my therapists, that if it comes up and you're not trauma specialist, this is what you do to help the client and then transition them to one of us. You did jump into, the addictions and then the trauma connection and that kind of thing. So I want to jump into that too, because I know that addictions therapy is something that you brought to the table early on and said that you had some experience in that. And so now you're the only one of us that does. And for me, that's, I've talked about boundaries in other videos or podcasts, and just a personal / professional boundary for me because of my past and someone that very close to me had issues with addiction. That's not something it would be too much countertransference for me. So then when you said addiction, I was like, okay, because it's not easy. Addiction is so, it can grab a person so much, and it's frustrating for the family because people see it as like, just stop drinking or just stop using. It becomes biological, psychological, all of that, right? What is something like treating addiction that you find really frustrating? And sorry, just because a therapist gets frustrated, I just want to clarify this, doesn't mean we're like, oh my gosh, right? It can be frustrating when we're trying to help a person and there's those stuck points, those blocks. That's an addiction has a lot of blocks, and it can seem very manipulative because the body's craving, right? So something that you find, I won't use frustrating, that you find difficult or challenging in treating someone with addiction.
So I did used to work in an addictions rehab center, and this is maybe where those frustrations were a bit more prominent, because it was a lot of people were coming there because their families were encouraging them, or it wasn't they weren't in the stage of change where it was them realizing for themselves that they had a problem. So a lot of times people would come, do the 30 days, and then leave, and we would do kind of checkups and things, and they would be back into they would have a relapse. And while that can be frustrating because they leave on a positive note, they kind of do go through those stages of change where they are kind of actioning those plans and finding strategies and things to help them cope and manage urges and cravings and all of these things. And then they do relapse and they're back and struggling again. So on a like clinical side, that can be frustrating, but there is another part that it's like relapse is part of addiction. So as a therapist, you know that is likely to happen, and we do teach that a lot. I always kind of preface like right from the get-go to kind of minimize that shame, that like if there is a relapse, if there is a lapse, if there is a use while you're kind of in this stage of change, that's okay, and to kind of accept that. So while it is frustrating, but it's also kind of expected. So I think that kind of helps a little bit. It's like, okay,
for sure,
this is part of the process. And there's a little bit of that like compassion that comes in, because it's like, okay, we knew this was likely to happen. Here's our game plan for when this does happen. That's another thing maybe that's frustrating too, is a lot of times clients that have realized that there is a problem and they are in that stage of change to want to maintain kind of their action plan and sobriety, but they don't want to recognize that relapse as part of it. So they fight that a lot, and that's kind of where that trap becomes, because then they don't have a way out. They don't have a game plan. So that might be the biggest frustration, is kind of that kind of push back on relapse prevention and kind of planning for that to happen.
Yeah. And I know, I don't treat addiction, but a lot, being trauma therapist, we call it short-term energy releasing behaviors. They're anything that when we're feeling that negative energy and that overwhelming energy, we tend to use behaviors to escape. And they're called short term because many of them can be, well, almost all of them can become addictive. So there's, there's alcohol, drugs, sex, sugar, food, chocolate, shopping. People joke and say retail therapy, but the spending and stuff is a real thing, right? It can become addictive. And like movies, video games, anything that's triggering the dopamine in your brain, because when you're feeling that trauma or whatever it might be, you want it to go away. And so you start with, oh, I'm going to go have a couple drinks with a friend. And then it's like, oh, I didn't feel it. So now I'm going to go have more. And now I'm going to, and then because of the parts of the brain it triggers, if you have a predisposition, addiction can come. So I know that trauma, in my experience, can lead to, the escape can lead to addiction. I'm not saying that if someone experiences a trauma, they're automatically going to become addicted. Do you see, well, two-part question. So one would be, do you see a lot of, like the clients that you do see or have worked with in rehab centers, do you see like trauma being the base? And the second part with that would be, is there like specific trauma that, like childhood abuse? Is that often like I call them the touchstone. Like in EMDR, we talk about the touchstone. And so often it's like the abuse is the touchstone. Do you see that, or is it more like just any trauma,
Yeah.
or is it trauma?
I would say a good majority of it is trauma. There have been some clients where it's just like boredom or lack of kind of coping skills, but and that could be that they just didn't get to the main touchstone of it. They're kind
Yeah,
of coming
yeah,
and saying, you know, I was bored and that was the reason that it led to this severity, and I would kind of guess that there is something deeper than that. I would, a lot of it is trauma, and I wouldn't say that there is a specific type of trauma, whether it is like childhood abuse or like one event that happens to them like later on in life. It's kind of that resiliency in how to deal with things that are happening in your life. And I know trauma can be kind of broad in terms of maybe what somebody categorizes trauma to be for them versus somebody else. So I don't
absolutely.
know that there's one specific kind. I think it's kind of
Okay.
subjective in maybe the resiliency in dealing with life events, if
Yeah,
that makes sense. But I
yeah,
would say
total
there's some
sense.
events. Yeah.
Total sense. And
Mm-hmm.
I have that analytical brain, right?
Yeah.
Obviously, we both do. Just that I'm always trying to figure out, catalyst or
Yeah.
whatever it may be. And I even like look at themes within like February theme and
Mm-hmm.
what a lot of clients come in, and just my experience with trauma when there is escapism and the addiction part of it, it is often childhood abuse. But I'm a trauma therapist, I'm not an addiction
Mm-hmm.
therapist. You would
Mm-hmm.
see more. So I just was very interested to
Mm-hmm.
find out
Yeah.
if you saw any of that. And how do you approach addiction from a trauma informed perspective? Like,
Yeah.
is it you tackle the addiction or do you tackle the trauma or?
Yeah, usually I kind of tackle the addiction first to get them stable, get them kind of those resources, being used to coping with day to day outside of using whatever that their substance of choice is. So that's kind of a lot of the relapse prevention. It's like you know, managing cravings and urges and kind of getting those coping skills in place. And then once they're kind of stable and feeling fairly good in their sobriety, then that's kind of how we would go in and tackle maybe the trauma side of things or getting to the root. But it's a lot of kind of, again, a lot of skills based in the beginning, kind of figuring out a little bit as to why maybe it started or what was going on when their using started to increase, or if they noticed at a certain point, like what was going on when they first started using, and kind of using that as that base, and then getting those skills and resources in place, and then tackling kind of the underlining touchstone, I guess,
Mm-hmm.
after that. So there's a lot of kind of
Mm-hmm.
stabilization in the first kind of few stages.
Okay. You're getting my wheels turning. Uh, because I'm just thinking, yes, most of my therapists want to be trained in EMDR, but
Mm-hmm.
you may be my priority to be trained in EMDR because of the connection, right?
Mm-hmm.
And
Mm-hmm.
anybody that calls us looking for help with addictions, we say, are you okay with online?
Yeah.
And you can do EMDR online. I do it online with clients. So file that. It's EMDR, for those of you who don't know, eye movement desensitization and
Mm-hmm.
reprocessing is like, I want to do a whole podcast on it,
Yeah.
right? It is, I get excited. I am a psych geek,
Mm-hmm.
but I get so excited when I see the shift, and the
Mm-hmm.
other day, this is kind of off topic, but on topic.
Mm-hmm.
The other day I had a 16-year-old client, and this client was only coming because mom and dad bribed, basically, said that they would pay for something for this client, a membership for something, so that as long as they went to therapy.
Mm-hmm.
And so I could tell that some of it 16 years old, right? So some of it was like, yeah, it's changing. Yeah. I'm like, no, it's not. You just tell me what I want to hear. But then I saw a
Yeah.
little bit of it, like they were
Okay, cool.
actually doing some of it. So I was okay. So then I saw them online last week because they were sick. And I bring up the memory again, the event
Mm,
again, and I say, okay, right now, how disturbing does it feel to you with 0 being not at all or neutral and 10 being the worst? And they had cleared it before, but sometimes, like when they're trying to just tell me what I want to hear, when that
yeah.
happens, they'll say, "Oh, I feel it a little bit." So I'm like, "Okay." So it didn't clear before, right?
Right.
But but this teen had their eyes closed, and then they're like, "I don't feel anything." Okay,
Wow,
you
that's
were doing
awesome.
it,
Oh,
right? But it was like this, like it's almost like they didn't believe it would happen, and
yeah.
it did. And so I get all excited. Actually,
Yeah.
the teen was all smiles too, so I was like,
Aw.
gotcha. But it is so cool. And
Hmm.
I've said many times that one of my, not one of the best part of our job, for me, my job
Hmm.
is when I see clients like doing that light bulb moment or
Right.
succeeding at something, or and they're
Hmm.
just like,
Hmm.
oh.
Yeah.
And so EMDR does that. It will fill your bucket all the
Yes.
time with clients. It's amazing. So can you walk us through you don't have to go into detail, but just a little bit of like a first session with somebody with addictions?
Yeah.
I know that people ask me, like, what do you do when someone, I also know that when we've given you clients with addiction, you tell me, or you
Hmm.
say that it's really important that they're connecting with their doctor
Yeah.
for
Yeah.
that part of it,
Yeah.
right?
Yeah.
So how would you approach somebody, out of the gate kind of thing,
Yeah.
first session?
So I kind of treat the first sessions a little bit the same as I would anybody. It's a lot of kind of that person-centered kind of information gathering. So like background, history, like where you are now, what's kind of present focus, what's challenging, what's kind of brought you into therapy, a little bit of kind of background of like family dynamics, anything that they're
Yeah.
comfortable bringing up. And I always preface like, if there's anything that we're not ready to talk about or not ready to hit, to skip it. And we'll kind of, as we build rapport and kind of go, then we'll kind of come back to those. But I am kind of assessing that when we are talking about where they are in the present focus, like where they are, they might be in that stages of change. So are they even realizing that they have a problem? So that might be like pre-contemplation. They're kind of not ready to think about it as a problem. They might be here because of they lost their job, and the job is the problem and not maybe using. So it's kind of assessing where they are so that I can meet them where they are. And then it's kind of understanding maybe what their usage does look like, kind of again going back to what was going on when we first started using, or when we started to see that pick up a little bit, or kind of understanding if there was an event around that time, or again, kind of that trauma informed when they're ready to talk about those things that might not even come up in the first session. It's a little bit like sometimes people are ready to dive into it and they want to kind of talk about their usage. A lot of times there's shame. So we might
Mm-hmm.
not get the full
Mm-hmm.
picture in that first session. Once we can kind of get to the stage of change where they are contemplating and actually kind of, admitting that they do want to change things, they are ready. It's kind of coming from a harm reduction standpoint. So what can we do to make sure that you're safe? So kind of that safety planning at the same time. A lot of times in the first few sessions, I'll get them to do like a cost benefit analysis. So
Okay.
like what are
Yep.
the pros and cons of drinking, for example, or using, and then what are the pros and cons of not using. So that kind of lays it out, and that kind of builds our standpoint or our resource to go back to if they are feeling an urge or a craving coming on. It really kind of solidifies why they're here and why they do want to make that change. So that's kind of the first few sessions that I do with people, is a lot of
Okay.
information gathering and understanding where they are in those stages of change.
Yeah, because I'm sure, I mean, just the way society sees addiction and stuff too, I'm sure that they have issues with trust.
Yeah.
And it would take a little bit to build that trust and
Yeah.
rapport with them.
Yeah. 100%.
So how do you balance empathy with accountability when addictions?
Yeah, so I use a lot of DBT for that. So, like the dialect that two things can be true at the same time. So, if there's kind of like, okay, I can understand why we would maybe give into a craving or an urge, and also how do we keep ourselves accountable? So, understanding the why, but also understanding why we're here. So, kind of going back to the cost benefit analysis of the cons and benefits and going like, okay, has anything changed there? Understanding maybe why we were in that position to, if we were in an unsafe environment that we've already kind of identified, or using that to kind of inform going forward. Maybe that wasn't an identified trigger for them, or an identified, unsafe person or unsafe wherever they are, whatever the situation
Yeah.
might be. So it's a lot of kind of understanding and using that as a point to move forward from.
Yeah. I think that, from what you're saying too, it's like in any therapy that we do, right? We're empathetic, but also if you want to see change, you need to move. You need to, do the work. And so there are times like with CBT, and because I'm more comfortable now, and you have to know your client to make sure that they're not going to. There was one client I had once, and I think I might have mentioned this in another podcast, but it wasn't addictions. They were stuck in this mindset of what people might see of them, and they were getting a master's degree, and siblings were in different professions. And so they were buying a house, or they were, and they were the oldest. And so I said, okay, then quit school and go into. And they looked at me like, well, no, I need to get my master's. Okay, so it's your choice. Right. And there was a lot of empathy before that, but just throwing that in there, that the accountability part, I listened, I validated, and then it was like, okay, then don't do it. Do something else. And they actually emailed me a little while later and said, that one thing that I did, that, okay, then quit, do something else, and then you can buy a house. They like that completely changed their perspective.
Wow. I love that.
Right. So when we can like be empathetic and validate, and then throw that in there for accountability, but this is your choice. I'm not saying addiction is somebody's choice. I'm not saying that.
No.
But we do have choices, right?
It's kind of that discrepancy a little bit of like, here's what you've told me, and here's what we're doing. Where's the in between there? What got us to that?
Absolutely, absolutely. And in that, I know that, and this is my personal / professional opinion, but not being an addiction therapist, but researching stuff and living it personally, not my own addiction, but like I said, somebody in my world, and working with teens in a school system. And we had somebody come in because at one point in Ontario, in our area that I live in, like the Ottawa area, there were people dying suddenly from fentanyl overdoses, right? And like is it carafentanil that was in it. And so we had people come into the schools and stuff like that. But one thing that I learned in all of that, and then I did more research in, when I used to watch the intervention shows and everything, and you see these interventions, and it's always, if you don't get the help, if you don't do this, I'm removing myself. And it's all about isolating the person with addiction, which what I've learned is the worst thing you can do. Intervention works, and I'm, like I said, it's not my specialty. So I've researched it now though, and I've learned things like they did a study, it was with rats, but they had, hopefully I get this right, they had like a cage with a rat in it, and it was isolated, and they had 3 vials of water. One had a drug in it, and the other 2 had water. And this rat went to the water, went to the one with drugs in it, and kept going back to the one with drugs. It was isolated. It was, nothing special in the... Then they put that rat and other rats in, they called it like the Central Park for rats, and they put it with other rats. And a nice environment and stuff. And then they did vials of water, and I can't remember how many, but there were more with the drug in it than the water.
Hmm.
And the rats went to the water, not the one with the drugs in
Wow.
it.
That's
Yeah,
so cool.
it was so cool, right?
Yeah.
So, and hopefully I got that all accurate, but that's basically, you know, what it was. And I was like, that is so cool.
Powerful.
And it shows that isolating somebody with
Mhm.
addiction, and if you disagree, that's fine. You can
Mhm.
tell me that.
Mhm.
But
No, I
isolating
agree.
someone with addiction is
Mhm.
not going to help them. They need that
Yeah.
support system.
Yeah. And there is a balance. There is a lot of boundaries that can be put in place, right, for the people that are supporting the person with addiction.
Absolutely.
But that doesn't mean kind of leaving them on their own, or that boundary means we're never going to talk to you again, or if there is kind of a fine line between that, but that support, um, like they'll be welcomed back at any point, or welcome to like in terms of whatever that person's boundaries are, whatever they're comfortable with, or it is a bit
Absolutely.
of a hard kind of balance to make, but
Absolutely. And I'm not, I mean,
mm-hmm,
I lived the other side of it.
mm-hmm,
I
mm-hmm,
lived you know, loving somebody
yeah,
with big time addictions,
yeah,
and I know the toll that it can play on
yeah,
you. And it's a lot. So
mm-hmm,
I understand.
yeah,
I totally understand why people want to isolate
mm-hmm,
those with
mm-hmm,
addiction,
yeah,
because it takes over your life, not just the
yeah,
person with addiction, but the people that love them too. And
yeah,
so I get that. As a whole, I
mm-hmm,
think that you're right. You need to have those boundaries
yeah,
for your own mental health
yeah,
too. But just, you know, bringing, first of all, my perspective, bringing somebody into a room, shocking them with all the people
mm-hmm,
that they love is
mm-hmm,
shaming, in my
mm-hmm,
opinion.
yeah,
Having each person tell them how they've hurt them and shamed them, to me, is,
a
I
breeding
don't
ground
think that
for
it's
shame. Mm-hmm.
supports mental wellness.
No, no.
But I do understand why they do it. I just,
Mm-hmm.
yeah.
Mm-hmm.
Anyway,
And
we could go on
even,
for an hour.
yeah, on that point too, right? Even if they were able to take in what everybody's saying in these intervention type shows, right? The person needs to be in the stage of change that's conducive to wanting to change. So if they're not even thinking it's a problem, none of that is going to be beneficial for that person.
Absolutely.
Mm-hmm.
Yeah.
Mm-hmm.
Yeah. Now you're making me think that we'll be doing a podcast on addictions. Lily just laughs at me because every time I'm doing a podcast, I'll be like, oh, all right, I think I'm going to do a podcast on that now whenever something comes up. But hey, weekly, we have a lot to do. So let's just kind of move into the online therapy
Sure.
that you're doing. And you can, even though I'm your boss, you can be absolutely honest, because I do know that online's not your favorite, right?
Mm-hmm.
But it's what we have
Mm-hmm.
for you so that you can hang out with all the cool chicks still, right?
Exactly.
But what do you like about online, and what challenges do you find
Mm.
with doing online?
I think online gives a lot of access to a lot of people. So I do like that idea that even if they aren't in the same city as me, or they could be 5 hours away, that we still can be connected. And it kind of gives that opportunity to find clients that I enjoy working with, and that they also have a good rapport with, that they feel comfortable with. So on the basis of like rapport and relationships, I do find it is a little bit easier that way, because like there's just a lot more options for people. So that's kind of fun. It is a little bit more relaxing. If I have a break, I can go and do something in my house, or pet my dog, or
Yeah.
go in my kitchen and get a snack, and not have to kind of organize that way. So
Yeah.
my online days are a little bit easier that way. It doesn't feel so much like I'm going to the office. It doesn't feel like work at that point. It's kind of
Yeah.
that passion part for me that is solely there. The idea of having to get up and get ready and go into the office and all of that kind of does feel a bit more like work. So when it is just at home, it's kind of like, okay, like I'm
Yeah.
just doing what I love to do. And I also get to go and pet my dog, or go for a walk in between, kind of thing. So it's a lot more free, maybe is the word I'm kind of going
Yeah.
towards there. There are some challenges. So on the same note of connection and rapport, You do miss parts of that kind of physical connection that you can make with people, which I do see kind of in person. The rapport maybe feels more natural in a sense because you are picking up on body language. You are kind of sitting in a space together physically, which I don't really know how to describe. It just feels a little bit different. It feels a little bit more connected. So
Yeah.
there are kind of two aspects to that rapport building. There's benefits and cons. Technical difficulties can be hard.
For sure, for sure. And
Mm-hmm.
assessing too, right? Like
Mm-hmm. Yeah.
because I do online on Thursdays. I work from home on Thursdays and I
Yeah.
do online only on Thursdays. And yeah, I get set up in my recliner that I you do most of my podcasts in with my laptop table and and I have it all set up there, but I'm like wearing track pants and a
Mm-hmm.
hoodie or something,
Yeah.
right? And I always say to my clients, this is the home version that you
Yeah.
get. Obviously I'm still professional, but
Of course.
there is, that comfort of it. And then I
Mm-hmm.
just walk into my kitchen at lunchtime and,
Yeah.
and I can get some stuff done because on my lunch at the office, everyone's
Mm-hmm.
coming in to ask me questions and everything, which is fine. And that's what they're
Yeah.
supposed to do. But then I do the paperwork that I could be doing at
Mm-hmm.
work at home. Right. So
Right.
there's that. But yes, it's the assessment part.
Mm-hmm.
Like right now you could be fidgeting and tapping your hands and everything and I can't see that, and that is
Mm-hmm.
a sign of stress and
Yeah.
anxiety.
Mm-hmm.
And or the foot tapping or the leg swinging and stuff like that, you can't see that. And telephone calls, we do them. I
Mm-hmm.
find them very difficult because you
Yeah.
can't see the person at all.
Mm-hmm.
You can't see the body language, the facial expressions, and tone sometimes even is hard on the phone, right? So
Yeah.
even video, you can see the facial expressions to match
Right.
the tone,
Mm-hmm.
like there's assessment going on. So
Mm-hmm.
yeah, so you would prefer in person or do you see merit in both?
I do see
Or I
merit in
guess it could
both.
be both. I
Yeah.
guess it could be both. You could prefer in person and
Mm-hmm.
there could be merit
Mm-hmm.
in both. Yeah.
Yeah. I think if I had to choose one, like if online, like if I could only do online or only do in person, I probably would pick in person. I lean a
Yeah.
little bit more that way, but I definitely do still enjoy online sessions. I do see merit in both of them, and it's kind of nice to have that balance of like, all right, Thursday's my completely online day, and it's a little bit like if you have a heavy caseload of in person, it feels a lot less maybe like heavy, I guess, on Thursdays in
Mm-hmm.
terms of my own mental health, my own well being, because I am at home. It's not an extra thing that I'm having to get up and do and go somewhere. It's kind of that okay, I'm still working, but it's in the comfort of my home and
Yeah. Yeah.
yeah.
Yeah. I think that, I agree. I prefer in person,
Mm-hmm.
but I think, well, COVID changed it all, right? Like the
Yeah.
pandemic with online and how wonderful, not
Mm-hmm.
the pandemic, but how wonderful that we have these opportunities.
Mm-hmm.
Like you said,
Mm-hmm.
I have clients that go away to school
Yeah.
and live 5 hours away. I've had a couple clients move across the country for school,
Nice. Yeah.
and they could still had access to therapy. And not that they wouldn't where they are, but someone that they're already established the rapport with and
Right.
comfort, right?
Yeah.
I have clients that wake up and they're not feeling well
Mm-hmm.
and they call, can we switch to virtual? Absolutely, it's
Yeah.
easy. Or
Yeah.
if I'm not feeling great, or one of the therapists, I think that we're blessed to have that
Mm-hmm.
opportunity to be able to do that. It's, yeah,
Yeah, I
yeah,
agree.
I
I
think there's merit.
remember in January, I actually got COVID. And for that week, I was online, like even in my in person, it was like, okay, I'm still feeling well enough
Yeah,
to work, but I of course
yeah,
don't want to pass that along. And so we just did it online and like snow days and things like that, where maybe it's
yeah,
dangerous to drive in, that you're able to still be there and support your clients, where maybe that would be disruptive to somebody's mental
a hundred
well-being if
percent.
you had to
Yeah,
cancel last minute. Yeah.
yeah, and we reach out to all our clients when we know there's a big storm coming,
Mm-hmm.
right? And
Mm-hmm.
say we can switch to online. We don't
Yeah.
want you driving, or if
Yeah.
they're sick, we
Mm-hmm.
say because we don't want you coming in, but I don't want to get sick either.
Exactly.
Right? So let's just do it online and we can't get
Mhm.
sick through the computer.
Yeah.
Yeah. Have you noticed any changes in like client outcome? Like, do you find that engagement and client outcomes and stuff is more, you see it more in person than online, or is it pretty much the same?
I would say it's the same. I actually had a client that I worked with in my placement, and so I saw them in person for the 8 months that I was there,
Yeah.
and then we moved to online, and the outcome is still the same. Like we've slowed sessions down because they're feeling well enough that they're kind of, I don't need as frequent sessions anymore. So let's kind of see how things go, and I'll reach out when I need to. So it's kind of neat, that
Yeah.
difference of like we worked together in person and we switched to online and then eventually to phone calls. So it's kind of all three of them, and we still got to
Yeah.
that
Yeah.
outcome. So I would say
Yeah.
no, like the outcomes are still the
Yeah.
same.
I
Maybe
agree.
engagement might be a little bit different with different populations. So the kid side of things is definitely a challenge online, but you get to see a bit more of their
Absolutely.
world too. So it's kind of a trade-off.
Yeah. Yeah. I remember during the pandemic having to switch to online with some of my kids,
Yeah.
and I was still seeing kids then. And like a couple of times I'm like, dude, you're going to make me sick. I'm getting seasick, because it was an iPad. Mom and dad would give them the iPad and they're
Yeah.
like lying on the floor, and then they're rolling, and then they're like, then it's down on the ground and they're doing something else. And I'm
Yeah.
like, hello, hello.
I'm still
And
here.
then and they'd pick it up. Yeah. Yeah. Or they put
Yeah.
it, even, when if I FaceTime my grandkids, right?
Mhm.
They forget that,
Yeah.
and they'll prop it up, but then they're off doing something.
Yeah.
They're like, I'm still here. Or
Yeah.
they're like walking
Come
around, and it's at
back.
the ceiling. Yeah. Yeah.
Yeah,
That
I've been put
engagement,
on a
absolutely.
few ceiling fans before, so I can understand the dizziness. You can't
Yeah.
stop it unless like you're kind of stuck.
No. Yeah.
There
And
is
like,
no
I was
redirection.
like, because I thought I was going to be sick one time, because it was like jumping and it was back and
Yeah,
forth. Yeah.
yeah,
Yeah. Totally. Totally relate to that and
yeah,
understand that.
yeah.
All right, we're going to start wrapping up a little bit,
Mhm.
but I just have a few more questions,
Sure.
like wrap up questions. Um, what is a clinical tool or like a framework that you rely on with your sessions, whether it's
Mm,
like the addiction or anxiety?
yeah. I think that really depends. I jump through CBT, obviously I use quite predominantly. Like reframing may be a big one there. Like the positive self-talk is one maybe that I use a lot of. DBT, I frequently use that in combination with the CBT. I
Yeah,
find that the dialect and explaining that two things can be true at the same time kind of keeps people in their feelings and kind of processing what they're going through. So the dialect, the two things can be true at the same time, is one I use a lot of. Just stress tolerance from DBT, kind of those skills. Motivational interviewing for the addiction side of things. So kind of
yeah,
rolling with what they're telling me, rolling with the punches, I guess, is an intervention
yeah,
there. So just kind of
yeah,
taking what they give you and kind of reframing it. I think the three of them really I use a lot of in pretty much every session. CBT would
yeah,
be like the main kind of backbone, and then I pick
yeah.
from those as well.
Yes. And do you know how much I love that you said rolling with the punches and stuff like that? Because I talk to all of the students that start with me, and you were the same as every other
Mhm.
student when you first start, right? It's like, okay, but I need to be prepared for that session. And what if? And I said to you, and I've said to every one of them,
Mhm.
you can be prepared, but they're
Yeah.
going to bring something else. You got to roll with it, right? You
Yeah.
have to roll with it. And so the fact that you
Mhm.
just said you just got to roll with the punches, I'm like, yes. And it is true, right? You
Mhm.
can be set up, you can
Yeah.
have a treatment. I mean, we have to have a treatment plan,
Right.
but you can have a treatment plan and have an idea of how you're going to do something that session.
Yeah.
And they come in with something completely different.
Mhm.
And I'm
Mhm.
sure with addictions, even more so,
Oh,
right? So
100%.
they come in with something completely different. And it's like, all right, then I'm just going to put these papers
Yeah,
over
we'll
here
just
and we're going to go with it.
pivot a little
And
bit. Hmm.
yeah, client-centered approach is what we do. At DCMP, you have to go with it. You have to roll with it. So I
Yeah.
love that you said that. I'm always like, oh, my little grasshoppers, right? Like, I love it. What advice would you give to somebody, either a new therapist starting out or somebody thinking about going into this profession?
Mhm.
Because I've done this for a long time, so I might have a different perspective than somebody who's newly into it.
Yeah. I think the biggest one is kind of accepting that we don't have all the right answers. We don't have the right way to do things. I think that's something that I'm still kind of grappling with. I think I've moved a little bit through that, but I remember, like, as you said, rolling with the punches. That was something that especially with kids, I found it really difficult to do because it felt more like it needed to be more structured, but at the same time,
Yeah.
it's not, because it's play based and kind of
Yeah.
going with what they need from you at that moment. So kind of being okay with just kind of being there, I think, is maybe the basis that I wish I had really felt when I know everybody kind of threw that at me and I didn't really understand it, I think. But it's kind of a neat moment where you go like, okay, I don't need to have all the right answers. Just because they're coming to me for help doesn't mean that I even know what the right thing might
Mm-hmm.
be for them. So yeah, just
Mm-hmm.
kind of that peace and acceptance that we don't always know the right thing to do, and there might not always be a right thing to do other than just being there. Yeah, I think that would be my
Absolutely.
biggest piece. And roll with the punches.
Okay.
I think that's a really good one.
Yeah.
It kind of goes
Yeah.
together. Hmm.
Yeah. Are you happy this is the choice you made in your career, your
Yeah.
profession?
Yeah,
Yeah.
it's very rewarding. There are challenging times, but when you work through those, it's like, okay, like this is why I'm here, and yeah, just seeing people's progress and finding their own strengths and seeing them realize that is a really neat thing to be let into people's worlds, and something that a lot of people don't get to celebrate with so many people and in a lot of different walks of life. It's really neat.
For sure.
Hmm.
For sure. And yeah, I mean, we don't deal in sunshine and rainbows all the time,
Yeah.
obviously, and days can get really heavy, but when you have
Hmm.
the sunshine, when you have those moments, it
Yeah.
reminds you, yeah, this is why I'm doing it,
Hmm.
right?
Hmm.
And you're still pretty new into it. And, you know, something that I try to work with all of you on is not bringing it all home,
Yeah.
not holding on to, we can't hold on to
Yeah.
everybody's, what they bring to us. And that's a
Hmm.
learning process
Yeah.
in
It
itself.
definitely
So
is.
if you could add, so my podcast is the Mental Playbook, right? Because I
Hmm.
like sports and stuff, but so I'm going to use a little play on that. If you could add one mental play to every client's toolkit, what would it be?
Hmm. Maybe self-compassion. I think that's a big one that people have a hard time understanding even what that looks like. And I think if people knew how to be compassionate towards themselves as much as they are for other people, that would be
Yeah,
a big tool in being able to reframe things and kind of look at different perspectives. And yeah, like I think that's
yeah,
kind of maybe the main
yeah,
one that I would think would be helpful.
absolutely. If we
Hmm.
could just like wrap up
Hmm.
self-compassion
Hmm.
and compassion for others into this little
Yeah.
like, yeah, yeah. I think for
Hmm.
me it would be that as and but also control, right?
Control.
Focusing on
Hmm.
what we can
Yeah.
control. That's something
Yeah.
I try to say to every client. What do you know to be true right now? And what can you control right now?
Hmm.
Not
Hmm.
what might happen, what can you
Yeah.
control right now? That's
Hmm.
something that a mental play that I want all my clients to have. So,
Yeah. I think that's a
um,
big one.
yeah. All right. This has been fun. This has been different.
Yeah.
First time we're doing video, but it's cool.
Yeah.
So thank you so much
Hmm.
for hanging out with me. I don't get to see you very often,
Hmm.
but when we do, it's always fun. So,
Yeah.
and I appreciate all that you do for us and for your clients. So thanks for hanging out.
Yeah, thanks for having
And
me.
for all of you, if you are thinking about going into psychotherapy or anything and you want to learn a little bit about it, or you know somebody who does, please share this with them. If you're listening to us on Spotify, please follow us, like, share, and on YouTube, subscribe, leave us a comment. If you have any questions about today's podcast, even about addictions or anything that we can help you with, and we'd love to hear from you. And as always, take care of you.